All right, so welcome back, guys. We're going to finish off the day with talking about the neurological system and musculoskeletal system. So hopefully you guys have some coffee or something to get you through the rest of today. This is going to not totally complete our med-surg content. We do have renal and endocrine, but we'll talk about that first thing in the morning tomorrow morning. And I want to start by saying with the neuro and musculoskeletal information, this is something that the NCLEX likes to include information on. And in their practice analyses, it turns out that there are a decent number of new graduate nurses who end up working on like a neuro med surg unit or an ortho unit or something like that. And so you end up seeing this content on the exam because, as we have discussed, the NCLEX exam is mirroring practice in that first year. So, all right, so we can go ahead and move on. We'll start with our first question. So I'll read this to you. We'll go through this. So the question is, the nurse is collecting data on a child and notes the presence of old and new bruises on the child's head and back. The nurse reports the following to the healthcare provider, knowing that which follow-up action for suspected abuse is necessary. Reporting the case to legal authorities, filing charges against the parents of the child, asking the mother to identify the person who is physically abusing the child, or telling the child about the need for foster care until the situation is straightened out. Excellent, good job. And this is usually what we see. We usually see really good performance on this particular question. It seems like you guys are familiar with the idea of, as nurses, you are considered to be mandated reporters. And and if you were to come across this in your practice, or you had a patient that you suspected abuse was occurring, you are required and mandated as a nurse to report that information to legal authorities. So nice work with that one. And one more thing I do want to mention, and you'll notice that we have pediatric content kind of threaded through these presentations in med-surg, and this happens to be one of our questions on children. When it comes to taking care of children, and in particular, if you're working in an emergency department, one thing that you may come across is something called shaken baby syndrome. And so I would just recommend that you be familiar with that going into the exam. It could be something that you come across, and there are certain physical injuries and manifestations that may be noted with a child with shaken baby syndrome. And so that's something that you want to be aware of. And remember that reporting is, especially on a test question, but just in general, if you're ever thinking that maybe it should be reported, then the answer probably is yes, that it should be reported. So always err on the side of reporting suspected abuse, because that will help to ensure safety. So nice job with that one. And we'll move on to the next question. We have a question here about an infant with hydrocephalus. Nurses caring for an infant diagnosed with hydrocephalus is monitoring for signs of increased intracranial pressure. The nurse suspects increased ICP if which finding is noted. Would we see proteinuria, bradycardia, a drop in blood pressure, or a bulging anterior fontanelle? All right, so let's go over this one. So you guys are doing really good with this, and it seems like this was adequately covered and addressed in your PEDS course. So the answer is going to be option number 4, as the majority of those who have responded, actually all of those who have responded, decided was going to be the answer. So increased intracranial pressure is a big concern because the cranium can only expand so much. And then what happens is the pressure of the brain structures can compress on to the respiratory center at the base of the brain. So you have this buildup of fluid in the cavities deep within the brain. That extra fluid puts pressure on the brain and it can cause brain damage. Hydrocephalus is most common in infants and in older adults. It is characterized by head enlargement in infants, and adults and older children experience headaches, impaired vision. They may have cognitive difficulties, loss of coordination, and sometimes incontinence as well. The treatment for this often is a tube or shunt that is inserted surgically into a ventricle to drain the excess fluid. And so in terms of this question, option number 4, a bulging anterior fontanelle, is going to be the answer here. So you guys did really good with that. On the next slide, we have a picture of hydrocephalus and what this looks like. So you can see where the labels are. So you've got the lateral ventricle, the third ventricle, the aqueduct of Sylvius, and then the fourth ventricle. So you can see how with the bulging as a result of the excess fluid, how it can compress on the brain structures, which then causes those manifestations that we just talked about. And then on the next slide, we have a picture of a ventriculoperitoneal shunt, which, as I mentioned, is the treatment for hydrocephalus. And so you've got that enlarged ventricle there, and you can see that that is where the shunt is placed, is in that area. And then it is actually kind of threaded down the side of the neck behind the ear. And it passes under the skin, and it will drain into a subcutaneous area in the peritoneal cavity. So that's the treatment for hydrocephalus, and you can actually see a ventriculoperitoneal shunt on somebody who has one. If you were to actually look, you can kind of see the shunt underneath the skin. So that's what that looks like. Nice job on that one. We'll move on and talk about autism. So we've got a question, and the question is, the nurse in a daycare center trains center staff to plan activities that will meet the needs of a new child with autism. The nurse understands that the priority consideration in planning activities for the child is to assure which intervention. Is it safety with activities providing verbal stimulation, social interaction with other children in the same age group, or familiarity with all activities and providing orientation throughout the activities? All right. Interesting. A little bit of a split here. 64 to 32% wanted to go with 1 versus 4. And then we did have the social interaction as well. So the answer to this question is going to actually be option number 1, safety with activities. And this is one of those questions where we have priority consideration. So going into that before even reading the options, that some or all of them are going to be good choices. So, but you just have to decide on what's the priority. And whenever you have an option that depicts safety, definitely consider that as the correct answer, as a priority versus the other options, unless the other options maybe depict a relevant physiological need. So with autism, it is a serious developmental disorder. It impairs the ability to communicate and to interact. Autism spectrum disorder is just that, the severity or degree or extent of the problem or disorder is on a spectrum. So one person can have a more severe case while somebody has a less severe case. It does impact the nervous system, and the range and the severity of the symptoms can vary widely. Common symptoms include difficulty with communication, difficulty with social interactions. They may have obsessive interests. They may have repetitive behaviors. One of the best things is early recognition, because the main, treatment approach for autism is behavioral therapy, education, family therapy, and these are approaches that help to reduce the symptoms and to support development and learning. Other than that, there's really not a lot of treatment options available for autism. There may be some nutritional changes that can be made to help with the symptoms. Certain medications aimed at comorbid conditions, but for the most part, the treatment approaches really center on therapy. So safety is going to be the answer to this one. Nice job on that. So on this slide, we're just showing head injuries, because we're going to have a question or two on head injuries. So when somebody has a head injury, it can happen obviously in a number of ways. And our biggest concern with somebody who is coming to see us and reporting a head injury or head trauma is going to be effects on the brain and on the nervous system. And so that's really what we're looking for when we're assessing for those things. You can see that, with the first image, this is where you have something, that's falling on the head, and you can see where on the brain that impact would occur, versus like a baseball hitting the front of the head, same thing. The injury occurs close to that site of impact. And then, if you have another situation, and this happens a lot with car accidents too, where you have kind of this motion of the head going back and forth, you can see where it's not so much affected in the front as it is in the back of the brain. Okay, so we often see occipital manifestations if you have somebody who has whiplash, or an injury that results from that kind of back and forth motion. So the way in which the injury occurs is important for determining then what part of the brain is affected. And what you'll see too is certain clinical physical manifestations based off of what area in the brain is impacted. And luckily we have imaging that can help us to see exactly where the damage has occurred, if it has. So the take home for this is just to be aware of, head trauma, and the way in which the injury occurred is important to know exactly which part of the brain is affected. So we'll look at a question now. The nurse is helping to admit a client to the unit who has a basilar skull fracture and notes clear fluid draining from the ear. The nurse concludes that the fluid is cerebrospinal fluid if which characteristic is noted. It's grossly bloody. It clumps together on the dressing. it's clear and tests negative for glucose, or it separates into concentric rings and tests positive for glucose. All right, very good. So the majority of you guys chose option number 4, which is the correct answer. So separates into concentric rings and tests positive for glucose. So a CSF leak, this is a condition that occurs when cerebrospinal fluid leaks through a defect in the dura, or it leaks through the skull and out through either the nose or the ear. And this could potentially occur as a result of a head injury. This is most often when we would see a CSF leak occurring. So the leak results from a hole or a tear in the dura, which is the outermost layer of the meninges of the brain. And causes of there being a hole or tear in that area could include head injury, as I mentioned, or it could be brain or sinus surgery as well. And so as for our correct answer here, this is called the halo sign. When we see the concentric rings, and we also do a test where we're testing the fluid for glucose, and glucose is present in cerebrospinal fluid. So if we were to see this appearance, the concentric ring appearance of the fluid, then we'd want to do this further testing to confirm that it was cerebrospinal fluid. So keep that in mind. This concentric ring aspect is kind of a hallmark sign of CSF, and this is something that very well could come up on the exam. So definitely remember concentric rings and associate that with CSF. As for option number 1, grossly bloody, what that means is that you can actually see without assistance, without a microscope, you can actually see the blood. So that's, like for example, gross hematuria means that you can actually see blood in the urine, versus microscopic hematuria, you can see blood in the urine, but only with the help of a microscope. So that's the difference between grossly, and microscopic. So it could be, CSF, even if we are seeing blood, but it isn't always, right? So just seeing blood doesn't necessarily mean that it's CSF. So that you would eliminate that option. And clumping together on the dressing, that is not characteristic of cerebrospinal fluid. It is clear, but if you look at the second part of that option, tests negative for glucose, that's not consistent with CSF. So you would eliminate that option. Okay, good work on that. Moving on, we're going to talk about somebody, again, another question on head injury. So I'll read through this one with you. Nurse is preparing a client for discharge from the hospital after a moderately severe head injury. The nurse should encourage which approach by the family in working with the client at home? Would we encourage them to feed and bathe the client, but then encourage independence with toileting? Provide for all of the client's needs and activities of daily living? Bathe and dress the client, but encourage independence with feeding and toileting? Or encourage them to become independent within individual limits of ability? Okay, nice work. So I don't think we need to go over this too much. This is A general guideline that I would use when it comes to any foundational types of questions, and similar to what Lisa mentioned earlier, in this case, you really don't need to know much about head injury in order to answer the question. So kind of a tip when it comes to test taking anxiety, just remember that before you get all worked up in your mind that I don't know a lot about head injury, let's say, read the entire question before you get to that place in your mind, because it could be that it's asking about, something that is related, but not exactly about that. So just keep that in mind and always remember to breathe. So so encouraging them to be as independent as possible. We really, really want to encourage that, because that helps just across the board. It helps with their recovery. It helps with their mental health. Being involved and engaged in their own care and in their own activities of daily living just promotes further improvement over time. And so as much as we can do that every day, it becomes really, really important in the long haul in their recovery. Somebody who had a severe head injury, or somebody with a spinal cord injury, or if they had a stroke and they're going through this long recovery process, it's really about the small wins for them, and those really add up over time to then be substantial improvement. Or it could be the opposite if we don't do that, and if we don't highlight the importance of that for them, they can then decline very rapidly and get to a point where they then have, irreversible kinds of complications. For example, you can get drop foot, you can get contractures, and no amount of physical therapy or range of motion exercises is going to correct that. So prevention is key, and doing a little bit every day is really, really important to get to. In a lot of cases, it's not about necessarily getting back to where they were before, but just getting to a place where they can be functional, is a realistic goal for people affected by these kinds of injuries. So very good. You guys did awesome with that. Keep that concept with you. It will apply to a number of different questions that you might encounter. The next question we have is about motor vehicle crash. So we have nurse in the emergency department is assisting in the care of a client involved in a motor vehicle crash and who probably has a minor head injury. So that's saying we're suspecting that at this point in time. The nurse would remove the cervical collar applied at the scene when which situation occurs? The client needs to use the bathroom. Results of the cervical spine x-rays rule out cervical injury. Healthcare provider prescribes head and scalp to be cleansed before suturing, or the healthcare provider determines the level of head injury after a neuro exam. All right, so you guys did really good with this too. You're doing really great with neuro so far. So yes, this is what we need. This is what you as the nurse, you need to have before you take the C collar off. You have to have those results, and it has to say that there is no evidence of cervical spine injury. In particular, at the level of C4, this is what drives your respiratory center. And so if there is an injury, if there's a fracture in that area, and we were to remove the device that is stabilizing the cervical spine, then that runs the risk of respiratory depression or the respiratory effort being impacted in a negative way. So it's extremely, extremely important. And And of course, too, there's also the risk of spinal cord injury in that case as well if the seat collar is removed. So as for option number 4, there really isn't a way to determine the level of head injury. And if you think about level of head injury, I mean, what does that really mean? And maybe extent of head injury. I could see the word level applying to when you're talking about a spinal cord injury, but maybe not so much with a head injury, right? And doing a neurological exam, while it does provide important information about focal neurological deficits as a result potentially of a head injury from being in the motor vehicle crash, it does not give us that definitive information. So that's another really good strategy for you guys to take away with you walking into NCLEX is when you're looking at these questions, does this give me the definitive information that I need to make a decision? Like in this case, to make the decision of removing the cervical collar, does the information depicted in that option give you that? And the answer would be no in the case of option number 4. So that leaves us to option number 2 as the answer. Okay, now we're going to talk about a halo vest. Nurse is reinforcing instructions to a client who's just been fitted for a halo vest. The nurse determines that the client needs additional information if the client makes which statement? I can use a straw to make drinking easier. I need to check my skin daily under the lamb's wool liner of the vest. I need to use caution because the vest alters the center of gravity and balance. I need to avoid nighttime driving because the vest limits my ability to turn my head. Let's see how you do with that. So this one's a little bit tricky. And, obviously the first place to start is going to be with our bolded red letters here, needs additional information if the client makes which statement. So we're looking for the incorrect response as the answer here. Okay, so for option number 1, I can use a straw to make drinking easier. Ask yourself, is that incorrect? No, that is not incorrect. That's correct. Somebody wearing a halo vest can certainly use a straw to make drinking easier. Absolutely. It doesn't imply and it doesn't say in this question that we're worried about dysphagia, and because that may be a reason why you would want to choose that option, because in some cases using a straw would be contraindicated in a case like that, but that's not stated here. So just go with what information you have in the question. And then I need to check my skin daily under the lamb's wool liner of the vest. Is that incorrect? No, we want them to check their skin daily underneath the vest to assess for skin breakdown, right? I need to use caution because the vest alters center of gravity and balance. Is that incorrect? No, that's correct. They do need to be careful. It does alter their center of gravity and it does alter their balance. And then lastly, I need to avoid nighttime driving because the vest limits the ability to turn my head. Is that incorrect? Partially incorrect, because yes, it does limit their ability to turn their head. So then they shouldn't drive at all. Not just avoid nighttime driving, they shouldn't be driving at all. Okay, so that leaves you with option 4 as your answer. That is what indicates that they need additional information if they were to make that statement. And I'll show you here what a halo vest looks like, and maybe that will help you to understand more, why it would be useful for them to drink out of a straw. Could you imagine drinking out of a cup wearing that? It doesn't have any give, it's like you're stuck in this position here. And the halo vest, it's not as common of a method of treatment. Similar to traction is not as common as a treatment for fracture, but it is still something that you'll see, and it does have safety implications associated with it. So you do want to be familiar with halo vest. Okay, now we'll talk about autonomic dysreflexia. This particular topic we have heard has been tested on the NCLEX, so you definitely do want to be familiar with this. So a client who experienced spinal cord injury is at risk for autonomic dysreflexia. The nurse should monitor the client for which manifestations of this complication: sudden tachycardia, pallor of the face and neck, severe throbbing headache, or severe and sudden hypotension. All right, so let's see how you did with this. Okay, this is interesting. So let's kind of go through this. So autonomic dysreflexia. This is a potentially life-threatening medical emergency, and it affects people with spinal cord injuries at the level of T6 or higher. So what you will see with somebody with a spinal cord injury at that level potentially is affecting the bowel and the bladder. So anything that irritates the bladder wall, such as a urinary tract infection, a blocked urinary catheter, an overfilled collection bag, or if they had a distended or irritated bowel, if they had constipation or impaction, hemorrhoids, infection anywhere along the intestinal tract, could potentially cause autonomic dysreflexia in these people. Other causes too could even be irritation of the skin, such as from the sheets being wrinkled, cuts, bruises on the skin, abrasions, pressure sores, or decubitus ulcers, which we do often see with people with spinal cord injury. Even ingrown toenails, burns, like burns from a sunburn even, or from hot water, or tight restrictive clothing are other potential causes of this. It can also be triggered by sexual activity, menstrual cramps, labor and delivery, ovarian cysts, certain abdominal conditions, as I mentioned, peritonitis, ulcers, colitis, or bone fractures as well. So if you were to suspect autonomic dysreflexia, the first thing that you'd want to do is you'd want to raise the head of the bed up to 90 degrees. And then if the legs could also be lowered, then you want to do that as well. And of course, loosen or remove any constricting clothing. Be sure to check the blood pressure like every 5 minutes or so to assess and determine if further treatment is needed to make sure that the blood pressure is stable. And so let's talk about what the correct option or correct answer is to this question. So it's actually going to be option number 3. A severe throbbing headache is a characteristic manifestation for somebody experiencing or going into autonomic dysreflexia. So with somebody who's had this type of spinal cord injury, this is definitely something that you want to be thinking about as a potential possibility. You want to do everything that you can to prevent that from happening. So that severe throbbing headache is a highly characteristic sign of autonomic dysreflexia. The others are not so specific to this problem. So remember, locate and remove the offending stimulus if possible, and begin by looking for your most common causes, thinking about the bladder, the bowel, the tight clothing, and the skin stimuli. And also something that might occur is that as the cause is removed, the autonomic dysreflexia may actually get worse before the symptoms start to improve. So that's something to expect with that. All right, so hopefully you know a little bit more about that because you guys were a little bit across the board on that question. So we have another question on spinal cord injury and autonomic dysreflexia. And so hopefully this will be an easy one for you, having just gone through that. So the client with spinal cord injury has experienced more than one episode of autonomic dysreflexia. The nurse should avoid which action which could trigger an episode of this complication? Rigidly adhering to a bowel retraining program, preventing pressure on the client's lower limbs, keeping the linen under the client free of wrinkles, or allowing the client's bladder to become distended. So let's see how you do. Hopefully this is kind of a mastered concept at this point. All right, yeah, nice job, you guys. We don't want to allow the bladder to become distended. I mean, even in the case of autonomic dysreflexia, but just in general too, right? Because that would be a risk factor for irritation and infection. So yeah, that would be something that we would want to avoid. Adhering to a bowel retraining program would be helpful. Preventing pressure on the lower limbs would be helpful, and keeping the linen under the client free of wrinkles would also be helpful. So nice work. Next question, we have a medication question. Client is receiving baclofen for muscle spasms due to spinal cord injury. The nurse monitors the client knowing that which is a side effect of this medication: photosensitivity, slurred speech, hypertension, or muscle pain. Okay, all right. So a little bit spread here too. A lot of you liked photosensitivity. So let's look here. So baclofen for muscle spasms. So it gives you the reason, gives you diagnosis of spinal cord injury, and we're monitoring for a side effect of the medication. So this is a muscle relaxer used to treat muscle spasms, and skeletal muscle relaxants like baclofen act directly on the neuromuscular junction, or they act indirectly on the central nervous system. So if you have one that acts indirectly on the central nervous system, like in this case, then you might see CNS effects as a side effect. So the answer is going to be option number 2, slurred speech is a side effect of baclofen. All right, next question. The nurse is assisting in developing a plan of care for an unconscious client. The nurse determines which nursing intervention as the priority: monitor temperature, maintain patent airway, administer tube feedings, or monitor neurological status. Hoping for 100% on this one. All right, so yeah, nice job. I don't think we really need to go too much more into that. This was kind of just meant to be there for you guys to show you that you're doing really well. So that should have been pretty easy. Nice job. Patent airway for sure. The next two questions are select all that apply questions, so we won't do the polling, so we'll just kind of talk through these. So nurse is describing the components of aneurysm precautions to a client who has a cerebral aneurysm. Which precautions would be discussed? Select all that apply. Do we want to keep the room lighting very dim? Yes, that is going to be an answer to this question. So we'll check that one off. Limiting regular coffee to 1 cup per day. Okay, so let's think about that. We're thinking about stimulation, right, with aneurysm. So if it's regular coffee, then that is going to cause stimulation. So let's not choose that one. Keeping the head of the bed raised to 15 degrees. So let's visualize that. What does that look like? Do we think that that would promote comfort? Do we think that that would be, problematic for somebody who has a cerebral aneurysm? Probably not. So we'll check that one and then we'll think about it some more. Avoiding activities involving pushing or straining. Yeah, that might make sense, right? When we think about an aneurysm and what an aneurysm is, it might make sense, right, to avoid those activities to prevent the aneurysm from becoming more severe and from potentially bursting. And ambulating in the hall 3 to 4 times a day. So if we think about that, that might be a little bit much for somebody like this. So I would choose options 1, 3, and 4, and those are going to be your correct answers. And so some of the things that you want to remember with aneurysm precautions: avoiding activities that involve straining, anything that could cause pressure and rupture of the aneurysm. You want to avoid the Valsalva maneuver, or the maneuver where they're bearing down, because that increases intracranial pressure by increasing thoracic pressure and jugular venous pressure. So, and if you recall, the Valsalva maneuver can have effects on heart rhythm as well, by those mechanisms. So it can do more than you would expect, but it's definitely a teaching point for somebody on aneurysm precautions to avoid the Valsalva maneuver as much as possible. And abrupt elevation of the blood pressure, which the blood pressure is so dynamic that, from 1 minute to the next, with the slightest change in activity, you have a change in your blood pressure, which is necessary for life. But in cases like this, those changes, and if they're too abrupt and too much, can cause problems. Like in this case, if often with an aneurysm, which is kind of like this ballooning, right, of a vessel, you have, because there's layers in your vessels, and the reason why you have an aneurysm is because in these layers in your vessels, you have this plaque buildup. This is the most common cause of an aneurysm, is your atherosclerosis, which can occur in any vessel in the body. But okay, so you have that, and you've got this kind of ballooning as a result of the weakened vessel wall. But then you've got this plaque, which is actually acting as a seal to that aneurysm. So if you have an abrupt elevation in the blood pressure, that can cause a dislodgement of that clot or that plaque that is sitting there sealing that rupture, which, if that happens, then that can cause rupture and bleeding. And bleeding of an aneurysm significantly increases the morbidity and the mortality for people affected by that. So even these simple things like we're talking about, Valsalva maneuver, those vagal maneuvers such as coughing, sneezing, straining, any kind of exertion, need to be avoided. All right, nice work. Next slide, we are talking about seizure activity. So nurse admitted a client who had seizure activity in the emergency department. The nurse should take which actions when managing the client's environment? Select all that apply. All right, let's go one by one here. So do we want to have IV equipment ready for insertion for somebody who recently had seizure activity? I'm going to go with yes on that. That sounds pretty good. Place padding on the bed side rails. So what would that do for us? Well, that's going to help us to prevent injury in the event they were to have another seizure. So let's go with that option. That's a good one. Keep the bed position raised to the nurse's waist level. Well, if you guys remember back to level 1, we do this if we're providing care, but then we're always lowering that bed back down to the lowest position. And if the bed was raised to the nurse's waist level, that's going to be in a higher position. So I'm not going to pick that option. Ensure that oxygen and suction equipment are at the bedside. Yes, I think I'm going to do that because I know that for somebody who's experiencing seizure activity, I know that they have abnormal electrical activity occurring in the brain, and I know that we have respiratory centers in the brain, and so we may need to give supplemental oxygen in that case. So I'm definitely going to have that ready to go. And then as for suction equipment, I do also know that oral secretions can be something that we see with somebody who's experiencing a seizure. And so I might keep suction equipment like a Yankauer suction catheter there in the event that we have to suction some of those secretions so that they don't get aspirated. Ensure that a padded tongue blade is taped to the head of the bed. So tongue blade, this is something that we used to do. We would have a tongue blade available, and sometimes we would insert like a mouth guard to prevent biting of the tongue, but that is an outdated practice and has actually resulted in injury for the people providing care to the person having the seizure. And you know, it would be considered an exposure if you were to be bitten, you know, and especially if the skin were to break. So that has become an outdated practice, so that you don't want to choose that as an option. You probably will see it as an option if you get a question like this, but just keep that as an option that you're going to eliminate. So seizure precautions are designed to protect the patient from injury. That's the biggest thing that you want to remember when you're going through these options. We want to protect them from injury, and we want to reduce environmental stimuli that may trigger the onset of a seizure. So that's the other thing that you want to keep in mind, similar to, I would say, the aneurysm precautions. So in general, seizure precautions include patient's bed in the lowest position, side rails are padded, and also, if possible, even having a mattress on the floor next to the bed is something that could be done as well. Loosening tight clothing, especially around the neck, such as a collar or a tie, to help with breathing. And when the convulsions stop, turning them so that they're lying on their side, and staying with them until they are alert again is really important. Okay. Now we have a medication question about phenytoin. Has been prescribed for a client for seizure control, and the nurse provides instructions regarding the medication to the client. Which statement by the client would indicate an understanding of the instructions? I'll use a soft toothbrush to brush my teeth. It's okay to break the capsules to make it easier for me to swallow them. If I forget to take my medication, I can wait until the next dose and eliminate that dose. If my throat becomes sore, it's a normal effect of the medication and nothing to be concerned about. Okay, so let's see. So answer here is going to be option number 1, which majority of those who answered, which is starting to dwindle, by the way, you guys. Come on now. I need more of you to start answering. And I also need the other 11 who decided not to show up to come. This is your NCLEX review. So important. Anyways, can you guys like text each other and be like, where are you? Like, why aren't you here? So yeah, option number 1, I will use a soft toothbrush to brush my teeth. So this medication is anticonvulsive, tells you that in the questions, it's being used for seizure control. And so one of the more common effects that can occur, side effects that can occur with phenytoin is gingival hyperplasia. This is a well-known side effect of phenytoin, and it's something that should definitely be brought up to the patient so that they can be on the lookout for it. They should have really good dental care if they're on this medication. And using a soft toothbrush to brush their teeth will help to prevent bleeding from the gingival hyperplasia, which is basically just swollen gums. And the other thing that I want you guys to know about with phenytoin is that it can cause agranulocytosis, which we talked about this with the prednisone, if you remember. If a medication has that as an effect or can cause agranulocytosis as an adverse effect, that then means that they're at a higher risk for infection. So we want any signs of infection, whatever they may be, sore throat being one of them, to be reported right away. So that's why you're going to get rid of option number 4. It's really important for seizure medications, if they forget a dose, that they take it as soon as they remember and that they're not eliminating that dose, because then what ends up happening is the seizure threshold is lowered if they miss that dose, or the longer it goes, then the lower that threshold becomes, and the more likely they are then to have a seizure as a result of missing the dose even. Really, really important that they're taking their medications just exactly as they are prescribed. And you guys know that general concept of not breaking capsules. That's not something that we want to advise them to do. So in addition to gingival hyperplasia as a side effect of phenytoin, which again is reddened gums, swollen gums that can bleed easily, we also have, because this medication has effects on the central nervous system, slurred speech, confusion, sedation, drowsiness. You can have nausea, vomiting as well, blurred vision and nystagmus, headaches. We talked about the agranulocytosis, also known as blood dyscrasias, which is technically defined as a decreased platelet count and decreased white blood cell count, right? So if you have less of those cells, then that means that your immune response will not be as robust as it otherwise would. You can also have an elevated blood glucose level. Some may experience alopecia or hirsutism, or so it's like one end of the spectrum and the other, hair loss or hair growth in areas that you wouldn't normally have it, rash or pruritus. And therapeutic serum levels to assess for toxicity is something that is typically done with a medication like phenytoin, which is one reason why it's starting to fall out of favor as being one of the preferred agents for seizure management. We have other medications now that are more preferred because they don't have as narrow of a therapeutic index and therefore do not require serum monitoring to assess for toxicity. So keep that in mind about phenytoin. We would be checking serum levels on that, and we'd be monitoring for any signs of toxicity, which, by the way, is ataxia or staggering gait. is one thing that we might see. And also this medication can cause lowered blood pressure and potentially cardiac dysrhythmias. So with those adverse effects, you can see why they're not as preferred as they once were. Okay, I think we're gonna have, I have one other point, but I think I have a question on it, so I'm gonna hold that for now. So we can move on. I think this is actually the one here. So next question, again on phenytoin. Client is taking phenytoin for control of seizures. During the assessment, the nurse notes that the client is also taking birth control pills. Which information should the nurse provide to the client? Pregnancy should be avoided while taking phenytoin. The increased risk of thrombophlebitis exists while taking phenytoin and birth control pills together. The potential for decreased effectiveness of the birth control pill exists while taking phenytoin, or the client may stop taking phenytoin if it's causing severe GI effects. Let's see what you do with this. Okay, so let's see here. Yeah, so a little bit split here, actually. And so the correct answer is going to be option number 3. Potential for decreased effectiveness of the birth control exists while taking phenytoin. This is pretty specific to this anticonvulsant. And when it comes to birth control and anticonvulsants, there are a number of considerations that we need to be thinking about. One of them being decreased effectiveness of the birth control. Okay. So if somebody's on birth control and they're prescribed this medication, they need to be informed of that, and they may need to consider an alternate form of birth control, perhaps one that is placed structurally, like an IUD or something like that, or an implant in the arm, something like that might be a better option versus the birth control pills, because it's the birth control pills in particular that may not be as effective. So that's going to be the answer here. And option number 1, pregnancy doesn't need to totally be avoided, which when you think about it, it's like, that's not even relevant, right? If you consider this option because they're taking birth control pills, like, it's kind of just like, what does that even have to do with this? Like, when I read this, I'm like, I'm just going to eliminate that because it just doesn't make a whole lot of sense to me. So I'm just going to take that one right off the table. Now, option 2, risk of thrombophlebitis. You guys may know that thrombophlebitis is a risk for birth control pills, and in particular with your combined oral contraceptives, your estrogen and your progestin birth control pills. Risk of thrombophlebitis is something that you would want to be aware about, and that the person taking them wants to be aware of. And they need to be assessed for risk factors for this. Age, do they smoke? Do they have a history of blood clots? Do they have a family history of blood clots, stroke, heart attack, anything like that? So thrombophlebitis is a risk for somebody taking birth control, and that risk becomes heightened with certain anticonvulsants, but not this particular one. So just to confuse you, phenytoin, this is a really important point when it comes to anticonvulsants in general, but phenytoin is not one of those that we're worried about in terms of anticonvulsant with that particular interaction or that risk being elevated. And then And then we already kind of touched on option number 4, client may stop taking the phenytoin if it's causing severe GI effects. We don't want them to just stop taking anything. We want them to call first, let us know what's going on. And if they were to just suddenly stop, that then runs the risk of seizures occurring. So we can get rid of that for those reasons. Okay, so hopefully you guys feel a little bit more confident about that now that we've gone through it. All right, next question. Client who experienced a thrombotic stroke has residual hemiparesis of the right arm and leg. The nurse caring for this client should place all objects in which area? I'll let you guys read through these because if I read through it, it's going to make your brain go numb. So we'll give you just a little bit longer to answer this one. Alrighty, so looks like you guys want to go with option number 1, which is the correct answer. So you guys did great with that. Okay, so let's look at this. So thrombotic stroke, residual hemiparesis of right arm and right leg. So where do we want to put all of the objects? You guys want to go with within their reach on the left side. So that's really good. So let's talk about what this is. So it's a weakness of that side of the body, of the right side in this case, as a result of the stroke. Okay. So what you want to remember with weakness, one-sided weakness as a result of stroke is when it comes to activities of daily living, first of all, they can get really, really frustrated very easily. So we want to make sure that we're setting them up for success with being as independent as possible. So within reach on the strong side, we don't want to test them by putting things just out of their reach or on the weak side. And so you guys did good. I don't think we really have to talk too much more about this. The only other thing I want to mention that might come up that's kind of relevant to this is unilateral neglect, which is an unawareness of a side of the body, and it's that side of the body that is affected, where they have this weakness or even a total paralysis. So think of it again as a lack of awareness of that side. And a common effect of stroke is that it can reduce the possibility of independent living, and it can also increase the potential for further injury because they have this weakness. And I mean, it's really very complex, the manifestations following stroke that can occur. And it does depend on what part of the brain was affected. And I remember having a question about this where there was an image of the brain that came up and it described the symptoms that were being experienced following stroke, and then it was asking which part of the brain was most likely affected. So, and then that was like a figure hotspot type of a question. So that's something that I would recommend you guys look at as you're studying, as you're going through the book. In the neuro chapter, you will see lots of information on hemiparesis, hemiplegia, the different types of stroke, and what you would see in terms of physical manifestations. So So good. And safety. Safety is a huge thing. People who have strokes, a lot of times they end up on neuro, like neuro med surge or neuro units. And those are the most difficult units to work on because of all of the safety issues and lots of falling, and impaired judgment coupled with weakness is just a really challenging area to work in to keep people safe. So, all right, good work on that. The next slide just shows some stroke lesions. You can see that the dark areas are the areas affected by the lack of oxygenation, and we're looking at necrotic tissue in the brain there. All right, next question is about a client who is recovering from a stroke, has residual dysphagia. The nurse instructs the unlicensed assistive personnel to avoid which action at mealtime? Giving the client thin liquids, allowing ample time for chewing and swallowing, placing food on the unaffected side of the mouth, feeding with food and fluid that have consistency of oatmeal. All right, excellent. So we're avoiding giving the client thin liquids. Yes, absolutely. The biggest concern here is going to be aspiration. Client with stroke, they've got residual dysphagia. It's already telling you that they're having difficulty swallowing. So thin liquids is going to cause that to be worse, and it could lead to aspiration. All of these other things will help to prevent that. Nice job. Next question. The nurse is teaching a client with stroke who has homonymous hemianopsia about measures to overcome the deficit. The nurse should incorporate which suggestion in discussion with the client? Wear a patch on the affected eye, try to avoid wearing eyeglasses, keep all objects in the impaired field of vision, or remember to turn the head to scan the lost visual field. Excellent. Yes. Remember to turn the head to scan the lost visual field. This is a condition in which the person is only seeing one side, whether it's right or left of the visual field. So if they scan like this, what that's going to do is allow them to see what they wouldn't be seeing if they just kept their head like in one position. So that helps to promote their safety. So nice job, good work. Okay, now we've got a question on myasthenia gravis. Client with myasthenia gravis has experienced an episode of myasthenic crisis. The nurse should gather data to determine if the client has which precipitating factor: infection, too little exercise, excess medication, or increased intake of carbohydrates. Excellent. So majority did go with the correct option here, which is option number 1. Let's go ahead and move to the next slide because we have an image here and also a description. of myasthenia gravis. So this is a neuromuscular disease characterized by weakness and abnormal fatigue of the voluntary muscles. And it's a defect in the transmission of nerve impulses at the myoneural junction. So with that description, you can have what's called a myasthenic crisis. And there are a number of precipitating factors of myasthenic crisis. And one of those things can be infection. If you're being asked about a risk factor for a condition or a complication, infection is a very, very common precipitating factor for a complication. So definitely consider that as a viable option if you see that as an option. Too little exercise in this case would not be a precipitating factor. It might be if there's too much activity or too much exercise. And then as far as excess medication, it's actually the opposite. If there's not enough medication, that could precipitate this. And then carbohydrates, there's no real association. So, okay, so good job. Most of you guys did get that right. And we'll talk a little bit more about this condition. It is rare. It's a rare condition. It's kind of a difficult thing to understand, and you might get a question on it, which is the reason why we wanted to include it in the review. It's possible that it will come up and it's just a really complex condition. So we'll go through it a little bit, but let's look at this question first. So another one, client with myasthenia gravis has discussed prevention of myasthenic and cholinergic crises with the nurse. The client demonstrates adequate retention of the information by stating that which aspect of self-care is most important? Is it taking all medications on time, taking vitamin supplements with meals, doing repetitive muscle strengthening exercises, or doing all errands in the morning when less fatigued? Okay, good. So taking all medications on time is the answer to this question. So notice the words most important. Which aspect of self-care is most important to prevent myasthenic and cholinergic crises for the patient with myasthenia gravis? All right, so again, myasthenia gravis, it is a long-term neuromuscular disease, and it leads to varying degrees of skeletal muscle weakness. You will see the most commonly affected muscles being those of the eyes, face, and swallowing. It can cause double vision, drooping eyelids, which we saw in the previous slide, trouble talking, and trouble walking. And it's caused by that error in the transmission of nerve impulses to the muscles. And so when that communication between the nerves and the muscles is interrupted at that neuromuscular junction, this is the place where nerve cells connect and then the muscles are controlled. This is then where you start to see these signs and symptoms. And, you know, complications of myasthenia gravis are possible, but really very treatable. But if they go untreated, it can be life-threatening. So that's another reason why it's important to understand a little bit, not a lot, but a little bit about this condition. And so these complications include myasthenic crisis. This is life-threatening. It can affect breathing, requires immediate treatment. And then, so there's that myasthenic crisis, and then there's also cholinergic crisis. And these two crises they manifest very similarly, almost the same, just like with an ischemic stroke versus a hemorrhagic stroke, the clinical manifestations are the same. So what do we need to do to determine which type it is? And why is that important? Why do we need to know which type it is? Well, because the treatments are vastly different, right? And if we were to give a clot buster to somebody having a hemorrhagic stroke, that's going to worsen their condition. Same thing here. So myasthenic crisis is due to insufficient medication, as we said with the previous question, or drug resistance. And then on the flip side, cholinergic crisis is due to excess medication, okay? So it's these cholinergic drugs that are used to treat this condition. And we do perform a test that allows us to differentiate between these two crises, so then we know how to treat it. And that's really, I think, the extent of what you need to know about this. And for sure, taking all medications on time is a really very important aspect of managing myasthenia gravis. All right, nice job. Again, very rare condition, but if you get a question, hopefully you'll get it right. Okay, so one more on this. So client with myasthenia gravis is receiving pyridostigmine. The nurse checks the medication supply to ensure that which medication is available for administration if a cholinergic crisis occurs. Do we need to have vitamin K, atropine sulfate, protamine sulfate, or acetylcysteine? Okay, yeah, so here's another area I think that we've identified where maybe you guys should just do a little bit more studying, which is good. We want to know that now. Okay, so as I said, somebody with myasthenia gravis, they're going to be treated with anti-myasthenic medications or anticholinesterase medications, which work by relieving muscle weakness associated with the myasthenia gravis. These work by blocking acetylcholine breakdown at the neuromuscular junction. You need acetylcholine for your muscles to work the way that they're supposed to work. And so these same medications that are used to treat myasthenia gravis can also be used to distinguish between the cholinergic crisis from a myasthenic crisis. And so examples of these medications, the anticholinesterase medications include neostigmine, pyridostigmine, and ambenonium. So the stigmines, those are the ones that you're more likely to see, and they're used to control those myasthenic symptoms. So that's an example or two examples of medications that might be used to treat this condition. And so what medication do we need to have available in the event a cholinergic crisis occurs? Well, let's talk about then what a cholinergic crisis may manifest as. So you may see abdominal cramping, nausea, vomiting, diarrhea. You might see hypotension and dizziness. You might see increased bronchial secretions, increased tearing and salivation, increased perspiration, bronchospasm, wheezing, and bradycardia. Okay, so there's the bradycardia. There's what's going to draw you to the correct answer, which is atropine sulfate. So if they're receiving this medication for myasthenia gravis, remember there's always this risk with this condition of these crises to occur. for cholinergic crisis, we're wanting to anticipate that bradycardia is something that we may see. And atropine sulfate is something that we use to treat bradycardia. And you may see this in other ways, like you might see somebody having symptomatic bradycardia as a result of a cardiac condition. And you would probably see atropine given at that time, depending on how low the heart rate actually is and how symptomatic they are. So, so again, you know, with all of these potential manifestations, just remember that these are life-threatening potential conditions. And so that's why we want to make sure that we have everything on hand that we need in the event that they were to lose their airway or they were to become bradycardic, hypotensive. As you can imagine, somebody like this would likely be in an intensive care unit. And then as for the other options, so vitamin K is the antidote for warfarin. And then protamine sulfate is the antidote for heparin, while acetylcysteine is the antidote for acetaminophen or Tylenol. Okay, next question. We're going to look at Parkinson's disease. The nurse is working with a client who has impaired mobility as a result of Parkinson's disease. The nurse should give which most helpful suggestion to the client? Sit in soft, deep chairs, exercise in the evening to combat fatigue, rock back and forth to start movement with bradykinesia, buy clothes with many buttons to maintain finger dexterity. Okay, let's see how we did with this one. So what we want to do, what the group wants to do is rock back and forth to start movement with bradykinesia. Good job. That's the answer to this question. So Parkinson's disease, let's talk about what this is. This is a disorder of the brain. It can lead to shaking, stiffness, difficulty with walking, balance and coordination. Parkinson's symptoms usually begin very gradually, very, very subtle in the beginning, and get worse over time. And as the disease progresses, people eventually may have difficulty walking and talking. So bradykinesia, which is like slow muscle movements, also constipation, fatigue, these things kind of trend in that body systems tend to slow down with Parkinson's disease. So, so rocking back and forth to start movement with the bradykinesia is very helpful when they're trying to just move in general. That's a good thing. And in particular, when getting up out of a chair, we recommend kind of doing this for a little bit first, and then, you know, starting to get up, versus sitting in soft, deep chairs. And in fact, you may have seen there's chairs that are made for this that actually like they go up high, first of all, so that they don't have to like stand up from a really low seat, but then also that tilt forward, just to make it less movement, less muscle that's required to get up out of a chair. And then, so exercise in the evening to combat fatigue. Well, no, that's kind of counterintuitive. Exercise is important across the board, no matter what, no matter who you are, no matter what health problem you have. Exercise is so important, and it does combat fatigue, but you want somebody, especially with Parkinson's disease, to exercise when they feel the least fatigued, which is most likely going to be first thing in the morning. And then Buying clothes with many buttons to maintain finger dexterity. No, let's just make life easier. Let's not do that. Let's not torture ourselves. Um, and with Parkinson's disease being a progressive, irreversible disease that gets worse over time, doing this it's not necessarily really going to help. Again, exercise, range of motion, all of these things are important, but when it comes to doing certain specific exercises, buying clothes with many buttons, it's only going to cause frustration. There may be exercises that are recommended to improve finger dexterity, but it's not going to be doing this. Excellent. So next slide just shows some of the clinical manifestations that we see in Parkinson's disease. So we can see this blank expression. They call it a mask-like facies. Very blank, expressionless face is common, especially as you get to the later stages. And then the gait, that kind of shuffling gait where they're really not picking their foot up off the ground to move forward and to stride forward, and they're kind of just shuffling their feet along, is very characteristic of Parkinson's disease. All right, so now why don't we talk about levodopa? Levodopa is prescribed for a client with Parkinson's disease, and the nurse monitors the client for adverse effects of the medication. Which finding would indicate that the client is experiencing an adverse effect? Pruritus, tachycardia, hypertension, or impaired voluntary movements? So I remember when I had a patient with Parkinson's disease who was started on levodopa, which is, it works to restore the balance of acetylcholine and dopamine in the central nervous system, which are the chemicals in the brain that are affected by Parkinson's disease. So levodopa works by decreasing signs and symptoms of Parkinson's disease and aimed at maximizing the client's functional abilities. And I'm actually really happy that most of you guys went with this answer. It is the correct answer, option number 4, impaired voluntary movements. With Parkinson's disease, a lot of students don't want to choose that as the correct answer because that is a manifestation itself of Parkinson's disease. So if we're giving them a medication, why would that medication cause that then? And if that is a risk, then why would we want to do that, right? But so this is one of the better medications that we have to treat the symptoms of Parkinson's disease, but unfortunately, it can have the same effect as Parkinson's disease. And it's a very individual response in terms of if the levodopa helps someone with Parkinson's disease and then the next person, it causes it to be worse. And I have seen that happen. And it's unfortunate when that happens because it's one of the tools that we have in our arsenal that if it doesn't help with the symptoms, then it's just really unfortunate because there's not a whole lot of options beyond that. Deep brain stimulation is something that is being used, but that is if they have failed medication therapy typically. So yeah, that is the answer. Impaired voluntary movements, although we're hoping that the medication actually helps with that, it can also be an adverse effect of levodopa. Alrighty, moving on. Next question. Nurse is reinforcing instructions with the client with trigeminal neuralgia about strategies to prevent episodes of pain. During the discussion, the nurse explains that the discomfort associated with this problem is due to which factor? local reaction to colds or flu, release of epinephrine with infection or stress, the effects of hyperglycemia on the cranial nerve, or stimulation of the nerve by pressure and temperature. Okay, good. Yes, answers option number 4, stimulation of the nerve by pressure and temperature. So trigeminal neuralgia is a chronic pain condition. It affects the trigeminal nerve, which is responsible for carrying sensation from your face to your brain. And if you have trigeminal neuralgia, even just the smallest stimulation of a certain part of your face, could be from putting on makeup, could be from brushing your teeth, could trigger this jolt of just excruciating pain. I don't know if you know anybody who has experienced this, but it truly is excruciating pain. And it can be treated, but it's something that if you've dealt with it, it's terrible from what I understand. So yeah, good job. Answer is stimulation of the nerve. Nice job. So we do have another question on trigeminal neuralgia. So client with trigeminal neuralgia tells the nurse that acetaminophen is taken on a frequent and daily basis for relief of generalized discomfort. The nurse reviews the client's laboratory results and determines that which indicates toxicity associated with the medication. Is it the platelet count of 400,000, direct bilirubin level of 2, prothrombin time of 12, or sodium of 140? Okay, good. Yep. So direct bilirubin level of 2, absolutely. So hopefully you guys recognize this name, acetaminophen, also Tylenol, and hepatotoxicity is a concern. And direct bilirubin level of 2 is elevated. Normally we see the direct bilirubin closer to 1. So a level of 2 is definitely elevated, and it could be a sign of hepatotoxicity. So you did good with that. And that actually wasn't a question on trigeminal neuralgia, just a question on Tylenol. Okay, let's see what we can do here. I think it's the same situation. So somebody with trigeminal neuralgia is being treated with carbamazepine. So what you can learn from this is that this is one of the treatments for this, right? Which lab result would indicate that the client's experiencing an adverse effect of the medication? Uric acid of 5, sodium 140, BUN of 15, or white blood cell count of 2000. All right, guys, we're doing really good. We talked about blood dyscrasias, and that's what a white blood cell count of 2000 is indicative of. Our white blood cell count is too low, right? And that is a potential adverse effect of the carbamazepine, which is also an anticonvulsant medication similar to phenytoin, and they share that same adverse effect, okay? Uric acid here is normal. 4.5 to 8 in male, 2.5 to 6.2 in a female. So that's normal. Sodium, BUN are also normal. And next slide just shows a visual for the visual learners out there of trigeminal neuralgia, which, as I said, sensory disorder involving the fifth cranial nerve, and it results in that severe recurrent sharp facial pain along the trigeminal nerve. Okay. Next, we have a question on multiple sclerosis. Client with multiple sclerosis is receiving diazepam. Which manifestation would indicate that the client's experiencing a side effect related to this medication? If they have a headache, drowsiness, urinary retention, or increased salivation. Okay, so this is one of our questions that isn't really asking about the disease process itself, but rather is asking about the treatment for it, which in this case is diazepam, which is a benzodiazepine. And if you guys recall, these medications are often also used as anti-anxiety agents. And so if you remembered that, that may help you to answer this question. So it's asking about side effect. Common side effect of your benzodiazepine definitely is going to be drowsiness for sure. So that's the answer here. These others are not, frequent side effects of those medications. And since we have multiple sclerosis on the slide, let's just briefly talk about what that is. And it's a disease of the immune system. And there's this protective covering on your nerves. And with multiple sclerosis, the immune system kind of attacks that protective covering in your nerves, which then results in nerve damage and disrupts the communication between your body and your brain. And it can cause a number of different symptoms, all the way from vision loss, pain, fatigue, impaired coordination, and the severity of it and the duration varies widely. Some people may be almost symptom-free, while others have very severe chronic debilitating symptoms that never go away. Treatments include physical therapy and medications that help to suppress the immune system and then thereby help with the symptoms and slow disease progression. So that's multiple sclerosis if you were to get a question on that. Next question we have is about baclofen, which is one of the potential treatments for multiple sclerosis. So let's see. So baclofen is prescribed for somebody with MS. The nurse plans care knowing that which is the primary therapeutic effect of this medication. So we talked about MS, so hopefully you can kind of deduce what therapeutic effect we would be looking for out of a medication. Is it going to be increased muscle tone, increased range of motion, decreased muscle spasms, or decreased local pain and tenderness? All right. Yeah, good. Majority wanted to go with option number 3, decreased muscle spasms. Yes, that is the primary therapeutic effect of baclofen. And just remember, we talked about this before with this medication, because it does affect the central nervous system, it can cause those CNS effects. Like it can cause drowsiness, dizziness, weakness, fatigue, constipation, things like that. Good job. So this slide here, the next slide talks or shows what can happen with that protective covering of the nerve fibers. And then, so like if you look at, shows the myelin sheath, that's that protective covering, shows where the nerve fiber is. Like in between that protective covering. And then further down, you can see that protective covering being impaired or damaged, and then how that then results in the nerve fibers themselves actually being damaged. A few more questions in neuro, and then we'll see how we want to finish up the day, if we want to go through musculoskeletal or see what we want to do there. So let's just finish this section first. Okay, so ibuprofen is prescribed for a client. The nurse should tell the client to take the medication by which method? Do we want to do it with 8 ounces of milk in the morning after arising, 60 minutes before breakfast, or at bedtime on an empty stomach? What do you guys think about that? Okay, so the reason why we have ibuprofen in the neuro section is because it's often used to treat pain. And this is a non-steroidal anti-inflammatory drug, and it is known for causing gastric irritation, and if taken frequently enough can actually cause ulcers in the stomach. So ways that we can prevent that from happening, the gastric irritation, is to take it with 8 ounces of milk. I think it was Linda who mentioned earlier that ice cream, right? The dairy components of ice cream can coat the mouth, coat the stomach. Same thing with the milk, same thing here. And so that actually can help to be kind of a protective effect with ibuprofen or other non-steroidals. Good job. Next question. Next question is, nurse is caring for a client receiving morphine sulfate subcutaneously for pain. Which priority nursing action should be included in the plan of care? Encourage fluid intake, monitor client's temperature, maintain the client in a supine position, or encourage the client to cough and deep breathe. Excellent. Yes. So it seems like you guys have this one down. So morphine, this is an opioid analgesic. Respiratory depression is a primary concern, and therefore priority nursing action would be to take measures to prevent respiratory depression. And coughing and deep breathing is something that, although it wouldn't directly address respiratory depression, because that results from results from changes in the respiratory center of the brain and the medication causing that effect. So although it doesn't directly address that, what it does do is it helps to improve oxygenation, helps to decrease the risk for atelectasis and therefore pneumonia, which, because morphine can cause a slower respiratory rate and potentially respiratory depression, those things are also risks. So that is a priority nursing action for somebody receiving morphine. Nice job on that. Next question we have is on a pain medication that isn't used as often as it once was, but for pain at least, but it is still used in the immediate post-op period for pain and also for shivering as a result of anesthesia. So you might see it come up. So meperidine is prescribed for a client with pain. Which would the nurse monitor for as a side effect of this medication? Would we look for bradycardia, hypertension, severe diarrhea, or urinary retention?
Just a quick note here, you will notice that in the poll, Number 1 says neurological system question. That is not one of your answers. I apologize. That's a
Oh, okay. No worries. Thank you. I will say, as you guys are answering this was a tremendous amount of work to put this together, and Devin has done a fantastic job, and I really, really appreciate it. I probably would have made a ton of mistakes doing this. So these little mistakes here and there are no big deal. And I thank you for all of your hard work. Okay, guys. Okay, yeah. This is a tough one. So imeperidine, as I said, it's used for pain, and it's used in the pre or post-op period. Some considerations with this medication is it can cause CNS depression, it can cause increased intracranial pressure, and so for those reasons, it should be avoided for people that have head injuries. And also history of seizure disorder should be avoided with them as well. So those are just a couple of points. But as far as a side effect that we would be monitoring for, the answer here is actually going to be option number 4, urinary retention, is a common side effect of imeperidine. The other name is Demerol. You may have heard the other name. And option number 1, believe it or not, this medication can actually cause tachycardia. This is one where I'm like, okay, it kind of causes opposite effects, which you wouldn't expect so much. So it doesn't cause bradycardia, it can actually cause tachycardia, whereas it doesn't cause hypertension, but it can actually cause hypotension. So it's kind of weird. And severe diarrhea, no, it's actually the opposite. It probably would be more likely to cause constipation, if anything. So with your opioid or narcotic medications, things that you would typically look for are slowing down effects. So like the urinary retention, the constipation, the hypotension. But then with the heart rate for this one, it's not the case. It's kind of a one-off. So urinary retention is what we're going to go with this one. And now we're on to our last question in the neuro section. So let's finish strong. Question is, the nurse is caring for a client with severe back pain and codeine sulfate's been prescribed. Which would the nurse include in the plan of care while the client's taking this medication? Restrict fluid intake, monitor for hypertension, monitor bowel activity, or monitor peripheral pulses. Hopefully you guys get this one right, because we kind of just talked about this.
So before you address this, Dr. Silvestri, Maru made an excellent comment in the chat.
I see that. Thank you for that. Well, I will have to look into this, Maru. Thanks for bringing that up. And I'll take a look tonight and we can look at it together again tomorrow. It could be an error. I appreciate you bringing that up. Thank you. Okay, so let's look at this last question here, which you guys did good with. So bowel activity, we did just talk about the slowing down effects of opioid medication. So codeine sulfate is another opioid medication. So we'd look for things like constipation, slowed gastric motility. In fact, you'll probably notice that for your patients in the hospital that are prescribed opioids, that they're also given stool softeners as a preventive measure to prevent constipation. So monitoring bowel activity is something that we're really on top of with people on opioids. So yeah, good job. And for that reason, we wouldn't want to restrict fluid intake because that would worsen the constipation. Okay, so with that, you guys, it's 3:08. We are planned to go to 3:30. I know it's been a lot of information today. And I want to kind of give you the option of, let me see what we have. So we've got about 25 slides for musculoskeletal. We could either press on and get through this up until 3:30, or we can table this until tomorrow. We should have time in tomorrow's schedule to fit this in after endocrine and GI. What would you guys like to do? Go ahead and just kind of type in the chat so I can get a sense. Diane, I appreciate the LOL. I get it. It's med surge. It's a lot. Okay, we're going to do tomorrow based off of that. And so for the rest of the time today, maybe we'll get out just a little bit early, but for the rest of the time, I'm happy to answer any questions that you have. And I know Linda was planning on joining us as well. So what questions do you guys have for us?
I just have one.
Yeah.
I've been struggling with this concept since level 1 because I can't seem to remember it. It kind of deals with musculoskeletal. It's just how to proper way to use a walker and a cane. I just can't remember exactly how to use it.
Yes. Yeah, that's great. Linda, I want to say that's in your, is that in your lecture tomorrow, in your section tomorrow?
No, I'm not doing musculoskeletal. No, that isn't, but
I thought it was in the safe, effective care environment, but I could be remembering that
not
wrong.
specifically about canes and walkers. It's more
Okay.
general, but just pulling the comp review book because we have, so is it, did he say canes and walkers and crutches?
Yes.
Okay.
And yeah, I'm looking too. I have it here too.
Yes, we have some great
whole
information.
section.
Yes, we have a whole section on that. And
what I'll say about that, Nick, is that's going to be straight memorization. I mean,
Yeah.
I can't think of another way to help you to remember that other than, you know, studying it, looking at it and memorizing it. I wish there was a way that I knew of to remember that. But honestly, I can't even tell you right now because I'd have to look it up like we are, but I want to tell you where it's at and where you can find it because I know we have it.
Yeah, I'm in the musculoskeletal section. And
Okay.
I know we moved some stuff around to make it easier for students based on their input of where they wanted things in the book. And so that, let me see, where did we put that?
I was looking
Okay,
in
so
foundations. Oh, you found
if
it.
you look on page 876 in the book, it talks about crutch walking, which you should probably read, all the different types of crutch gaits, canes and walkers, and it provides you the instructions of what you would tell a patient to do. Okay. So 876 to 877 is all the information you need on that. So
yeah, and there's a
take a look at
table
that.
too. There's
Yes,
a table.
There's a table for the crutch gaits, and there's a section on crutch walking and canes and walkers. And so, you know, you might take a look at that, and if you have any
Yeah, and
questions.
going up the stairs and down the stairs and, you know, which leg they move first. And yeah, and it's hard to remember. It's hard to remember. I'm gonna look at this too, and we can talk more about it tomorrow, but that's
Yeah,
where you can read about it.
The way I always remembered crutches and going up and down stairs is if you're good, you're going to go up to heaven. So you always take your good leg first.
Oh, there you go. That's
And
great.
if you're bad, you're not going to heaven, you're going to hell. So the bad is first when you're going down.
The bad leg goes first.
Yes.
Okay,
It's just
that's
a little
helpful.
simple trick that I had to remember. What goes first when you're going up the stairs, your good leg. And what goes first when you're going down the stairs, your bad leg.
So does that help, Nick?
Yes, it does. Thank you. I'll check out those pages.
Perfect.
Yeah, just check those pages and I think, you know, it's pretty easy, basic stuff. And you might see a question on that, like evaluating a patient who's walking with a walker and you notice this, that, and the other thing, and, you know, what would you do about it? But that could fall under safe and effective care environment client needs, or under physiological integrity, because mobility is also there. So it's hard to know. And if you would or would not see a question on this.
Yeah, because it's foundational.
Very foundational.
And they tend not to focus on that content. So yeah, I'd review it, but I wouldn't drive yourself nuts, Nick, on
No.
that one. And I was just looking, Linda, so page 863 in our book, we do have tachycardia as a side effect of the meperidine. But one of our students found conflicting information on Nursing Central that bradycardia is a side effect. So we might
What
have to
page
just
are you on?
863.
And you're under meperidine?
Yes. Letter E, meperidine.
Okay, and
So we had a question on it,
Yeah.
and so tachycardia is here in our book, but Maru found that bradycardia is actually a side effect. So just conflicting.
well, yeah, this is talking about side and adverse effect. And you know, with any of these opioid analgesics, you know, they're going to cause respiratory depression, most of them. And, but the response to a lot of times with that respiratory depression is a tachycardia. You know,
That's a good point.
Yeah. And so that's why, you know, we'll see the tachycardia in people. But
yeah,
with
that's a good point. Go ahead. Sorry, I didn't mean to cut you off there.
With the meperidine, we're not using that drug that often anymore because of the risk of, you know, seizures. And so we don't see that often anymore. But the other thing that you really want to hook up with meperidine, because see, these drugs also have a little bit of specifics. Now with morphine, you always want to remember respiratory depression. Meperidine, one of the big things that we've seen them ask about on NCLEX is urinary retention. Okay, so they probably wouldn't ask you about the bradycardia and the tachycardia, because yes, bradycardia will occur as a result of the effects of the drug, but as a response of the body to that respiratory depression, they end up with a tachycardia, which is then an adverse effect also. So they're more likely to ask you about the urinary retention than the bradycardia or tachycardia.
It's a great point. And because I was explaining to them that with the opioid analgesics in particular, you see this slowing down of multiple systems. So you see like that urinary retention, the constipation, the drowsiness, the respiratory depression, and hypotension typically, right? So I think, Maru, I think what it is that it's kind of both, as Linda is saying. So like if you see that hypotension initially, the body's initial compensatory response is going to be a tachycardia. And then if that persists, then eventually you could see a bradycardia. So I do think it's both.
It is both.
So that makes it a very complex kind of discussion, but I do think it's kind of all of the above. Thank you, Linda. That's a great point and a great way to think about it.
And I've always told students in terms of NCLEX, you know, respiratory depression is the big thing. Specifically with morphine. And then meperidine, urinary retention, codeine, constipation. Remember those
Mhm.
points about those drugs, and those are the ones that they're probably going to ask you about. Yeah.
Excellent. Great. Do you guys have any other questions? I think we had a good day. You guys did great. You hung in there with me. Really appreciate that.
Excellent questions and points that they're bringing up too. That's very impressive.
Yes, I agree. I think they're going to do really well.
Mm-hmm, mm-hmm.
All right, you guys. Well, why don't we call it a day? How's that sound? And we will see you back bright and early tomorrow morning. Before you go, let's find out from Devin which link we're going to go into first tomorrow. It's going to be, I think, link 8, endocrine and GI. Is that right, Devin?
Is it endocrine and GI or endocrine? Is there renal somewhere?
Renal is the next link after that.
Oh, so they have endocrine, GI, renal, and then musculoskeletal tomorrow.
And your safe, effective care.
Yeah,
Yes.
that'll be the fun
Mhm.
part. Well, we'll save that for last. That'll be the easy,
That sounds
kinda,
great. Yeah. We'll do that at the end.
like I always say at night, I'm so tired from everything all day. I'm going to watch mindless TV.
Yeah.
So, the safe and effective
Exactly.
care environment will be your fun, mindless time. How's that?
I think that's perfect. Okay, you guys. So we'll see you in link 8 tomorrow morning at 8 a.m. Have a great evening. Thank you so much. Thanks, Linda.
Oh, you're welcome. Thanks, everyone. Great day.
Thanks, Devin, for posting that. Bye, guys. Have a good night.